Hi guys, welcome to lecture via audio recording. The whole goal behind audio recording is to make it to where you can start and stop your PowerPoints as needed. I know a lot of you may have distractions at home and it's rather difficult to accomplish studying at home. So hopefully the audio recording of these PowerPoints will be beneficial to each of you. All right, so for cardiac flow or forward flow, there are some links in the notes section on Canvas below this PowerPoint. I would like you to utilize those links to review the cardiac blood flow. So I'm not necessarily going to review the pathophysiology behind it because our focus is more so medications and the pharmacology of in terms of how it affects cardiac. So this is a pretty good little diagram or cartoon here that shows the difference between preload and afterload. So cardiac output is the stroke volume times the heart rate. And essentially what we learned from cardiac output is how much blood is being distributed to the peripheral tissues. So preload is that volume of blood in the ventricles, and we can think of that as that end diastolic pressure. And things that increase preload would be hypervolemia, so an increase of fluid volume or regurgitation of the cardiac valves. So essentially this blood flow that is backing up from the ventricles into the atria. And then afterload would be that resistance that the ventricle must overcome to circulate the blood throughout the body to the peripheral tissues. So we can think of if there is increased afterload, there is increased cardiac workload. And remember, the heart is one of those muscles that we do not want larger. We do not want this muscle overworked because it loses the ability to contract and pump blood to the peripheral tissues. So heart failure is basically that inability to contract. The muscle becomes large and weak, and that inability of the ventricles to contract essentially leads to the inability of the heart to meet the metabolic demands of the body. There are many things that can cause heart failure. One or some of the more common causes would be the triad of hypertension, diabetes, and usually increased cholesterol levels. So there are some lists here. Diabetes is listed twice, but hypertension, hypercholesterol, or high cholesterol, and diabetes would probably be some of the three most common causes from this list here. Also, myocardial infarction. So if the patient has had a previous ischemic event that led to infarction or essentially the muscle not receiving oxygen, this can also lead to that weakened pump or weakened heart muscle. So in reviewing heart failure, there are two different types of heart failure, actually three. So left-sided heart failure, which we see here on this slide, right-sided heart failure, or a combination of both. So focusing in on this left-sided heart failure, this is a pretty good cartoon that depicts some of the more common signs and symptoms of left-sided heart failure. One thing that I want you to correlate is left lungs. If you can sort of remember those two together, the patient that has left-sided heart failure will have a lot of respiratory signs and symptoms. So their lungs will be affected. Coughing, crackles, wheezing. This fluid is essentially backing up into their lungs. So then moving on to right-sided heart failure. What we can see here by this cartoon is that the right-sided heart failure affects more of the body. So if you think of right in relationship to the body, what you can see here is that the patient has a lot of peripheral edema, so swelling in the hands and the fingers, as well as the feet, so that dependent edema here. The swelling can also occur in the abdomen area, which would be the ascites, and so these patients have a lot of backup fluid third spacing, essentially. These patients generally do not have the respiratory symptoms as the left-sided heart failure patients would. So when we're taking a look at this slide here, which of the following can increase cardiac output? It can sort of be deceiving in terms of the words decrease. But what I really want you to focus here is on the afterload. And that afterload is the force against which the ventricles must act in order to eject blood. And so by reducing afterload, you can essentially increase cardiac output. So a decrease in afterload would be a way to increase cardiac output. And for those of you that like diagrams, this is a diagram here depicting the management of heart failure. So if you learn by diagrams, this is a great diagram for you to work your way through. So picking back up into the discussion of the ACE inhibitors and ARBs, we left off in terms of talking about decreasing the cardiac workload, but also these medications lower the peripheral vascular resistance and they inhibit aldosterone. So think about that renin, angiotensin, aldosterone system that you guys have previously learned about in your pathophysiology class. These medications also lead to dilation of the veins. These medications can have some side effects such as hypotension or low blood pressure, syncope, which is where the patient is passing out, or a cough. And that cough is sort of that telltale side effect that is pretty common with these groups of medications. And then we go into the cardiac glycosides, focusing mostly on digoxin. And so digoxin really works in terms of increasing that cardiac contractility. And this class, or digoxin, would be known as a positive inotrope. And when you think of that positive inotrope, think about it in terms of contraction. And then when the negative chronotrope, think about it in terms of heart rate. So negative would mean that it is slowing the heart rate also. And it does this by affecting the impulse conduction by the SA node. So the SA node, remember, is that main node of the heart. And so by affecting the impulse, it essentially will slow down that main node or the SA node of the heart. Some common side effects with this medication would be a dysrhythmia or an AV block. So what's really important here in terms of digoxin, we see this little cartoon here talking about the serum digoxin level in the cardiac tune-up center. But before administering digoxin, you always want to make sure that you check the patient's vital signs, specifically that apical pulse. And so that apical pulse, you would want to hold this particular medication if the heart rate is less than 60. You want to check potassium levels for this medication also. Potassium levels of less than 3.5 can cause digoxin toxicity. And so digoxin toxicity would be a level greater than 2. And as nurses or healthcare providers, this level would be monitored or checked basically through a laboratory value. So you want to monitor the electrolytes as well as a digoxin level. You don't want to give this medication with tetracycline and erythromycin because it increases digoxin levels. Normal digoxin levels would be 0.5 to 2, and the antidote for digoxin toxicity is Digibind, and it does exactly what that name says it does. It binds the digoxin in order for it to be excreted out of the body. Some common side effects, or probably the most common side effect of digoxin or digoxin toxicity, would be seeing yellow halos. So the patient will complain of their vision changes and visual disturbances, and they say that their vision has changed to see yellow halos. So moving on now to the additional drugs for heart failure, beta blockers. Beta blockers are pretty common, and so they have a negative inotropic effect, which remembers would mean that that heart rate is slowing down, and they are given to suppress the effect of the sympathetic nervous system on the heart. So remember that sympathetic nervous system would naturally be increasing the heart rate, and the beta blockers, we want to give them to slow the heart rate down. These medications must be given very slow, and their doses must be doubled every 2 to 4 weeks until that desired dose is achieved. This medication is usually combined with ACE inhibitors, and some common side effects would be dysrhythmias and ischemia. For this particular medication, there is a black box warning, which is do not abruptly stop. So always when studying your medications, just sort of know those black box warnings. Another medication that's mentioned here on this slide would be, or classification, excuse me, would be loop diuretics. And so specifically here, we're talking about Lasix. And this is what is given to sort of remove that fluid off of the body, that third spacing that we see occurring. This medication decreases preload, but it does have a side effect of hypokalemia. So we would want to make sure that we are checking the patient's potassium levels when administering this medication. As a nurse, we would want to hold this medication if the potassium is low and consult the physician. So moving on with additional medications for heart failure, we have a direct vasodilator. And so Natracor, which would be given via IV route, basically helps it vasodilates the vessel. And so when we think about this, our heart naturally secretes BNP, which is essentially a hormone which is released by the heart and blood vessels. And so this hormone naturally vasodilates the vessels. And what you can see here on the diagram to the right is a normal heart versus a congestive heart. And so you can see how vasodilation would be key in terms of bringing circulation to the heart. Some side effects of this medication would include headache and dysrhythmias. And then we move on to Betel, and this is a combination of hydralazine and isosorbide. And so really the goal and focus of this is to relax those blood vessels. But again, this medication has side effects, which would include reflex tachycardia or fast heart rate and a headache. Moving on with drugs for heart failure, I'm going to talk about the phosphodiesterase inhibitors. And so an example of this would be Primacor. One thing that I want you to recognize is just that these are not for long-term treatment. These are ultimately given continuous IV route, and the overall goal behind using these medications would be that they vasodilate and increase contractility. So you can consider this class of medications as a positive inotrope. In the next slides, I'll be doing a few practice questions with you guys. Okay, so now starting some of the practice questions, we'll start with this first question here. These drugs are used as first-line treatment of heart failure. They work by allowing more blood to flow to the heart, which decreases the workload of the heart and allows the kidneys to secrete sodium. However, some patients can develop a nagging cough with these types of drugs. And the answer would be D, angiotensin converting enzyme inhibitors, so the ACE inhibitors. A patient with heart failure is taking losartan and spironolactone. The patient is having abnormal EKG changes. Which of the following lab results confirms these findings? The answer is C, potassium of 8.0. A potassium of this high essentially is lethal, and these patients would have very tall peaked T waves on their EKGs. And because they are on spironolactone, this is a potassium sparing diuretic, which means that the potassium is not excreted when fluids are removed from the patient. You are taking care of a patient with heart failure. The patient is on the following medications: Lasix, potassium supplements, and digoxin. Which patient comment should you be most concerned about? The answer is C, I'm starting to have trouble with my vision. Remember, these patients see those yellow halos, which is a sign of digoxin toxicity. So any kind of vision troubles while the patient is taking digoxin, you would want to be monitoring those digoxin levels in fear of digoxin toxicity. The physician order says to administer Lasix 40 milligrams IV twice a day. The patient has the following morning labs. Sodium is 148, potassium is 2, and BUN is 10. Which of the following is a nursing priority? The answer is D, hold the dose and notify the physician about the potassium level. So remember, Lasix removes potassium from the body. Normal potassium range is 3.5 to 5. The potassium here is 2, which is low, and that is essentially why we would want to hold this medication. Now moving into angina or chest pain. This is an acute form of chest pain, and this is due to a lack of oxygen to the muscle or to the heart itself. The lack of oxygen is what essentially leads to that pain, pressure, or discomfort. Coronary artery disease is the most common form of angina, and it affects 10 million Americans. So pretty significant, and it's multifactorial in terms of causes. So the goal in fixing or treating angina is to restore that oxygenation to the heart. And if the issue is that vessels are occluded, we want to administer medications such as nitrates, which would vasodilate. And so this vasodilation increases oxygen to the heart. Isordil is another medication, and this one causes dilation as well, which essentially decreases preload and afterload. This decrease in preload and afterload reduces cardiac output and workload. These medications do have side effects such as a headache, decreased blood pressure, syncope, or flushing. But another thing that you would want to sort of be concerned with is, especially with the nitroglycerins, is you want to see if the patient is taking any medications that may affect or enhance sexual performance. So a lot of men that are taking medications such as taking such medications as Viagra, because if the patient is taking Viagra and takes a nitroglycerin, it essentially can be lethal for the patient. So we learned about some of these medications for heart failure, but these medications can have multiple uses, such as beta blockers. So these beta blockers reduce that cardiac workload, and this reduction of the cardiac workload, it helps relieve the workload that the heart is having to do, which decreases that pain. This is a drug of choice for stable angina or stable chest pain. Also cardiac or calcium channel blockers, Norvasc, and this one relaxes those smooth muscles. So essentially the blood pressure and the O2 demand would be decreased by this medication. This medication also dilates the coronary arteries to increase cardiac blood flow. So these are good for vasospastic angina or patients who cannot tolerate beta blockers. So I talked about that angina or that chest pain being as a result of tissue ischemia or hypoxia to that cardiac muscle. But with this angina, it's sort of that precursor to a myocardial infarction or MI, heart attack, maybe the slang term for this here. And so this occurs when there's a complete occlusion of an artery or near complete occlusion of the artery. And so this plaque that is building up essentially leads to the clotting cascade to sort of increase. And this blockage of blood flow to the heart results in decreased oxygen to the heart. So this decreased oxygenation for a prolonged period of time results in tissue death. So it takes about 20 minutes of hypoxia to the cardiac muscle to result in tissue death. So really the goal of treatment for patients that are suffering a myocardial infarction is to restore oxygenation. You want to think time is muscle. So the quicker we can restore the oxygenation or the blood flow to the heart, the better the outcome for the patient. really the goal would be to reduce mortality and relieve the pain after we have restored the blood flow to the heart. In this diagram here, what it is showing is basically a heart that is being damaged. You can see the damage that's indicated here in purple, and this is a result of that occlusion. And so the circle on the upper left of the slide is indicating or showing how there is a buildup of plaque in that coronary artery, which is creating an occlusion, blocking blood flow and oxygen to the heart. And so this purple area, without relief of the symptoms or restoring blood flow and oxygenation, can become permanent damage, which leads to heart failure. So some types of medications that would be administered during the acute phases of a myocardial infarction would be thrombolytics. And these are the first line medications that would be given rather quickly. So TPA or streptokinase are two of the medications that are commonly given in the acute phases of myocardial infarction. There are contraindications to administering these medications, such as bleeding disorders, patients greater than 75, or a narrow margin of safety. So risk versus benefit when administering these medications. Aspirin would be given as soon as an MI is suspected. Plavix is an antiplatelet, and so these patients will usually be on Plavix post-procedure, and then additionally anticoagulants such as heparin, Lovenox, or Coumadin. One easy way to remember the treatment for myocardial infarction, and there really is a variance in order, but if you can remember the acronym MONA, morphine, oxygen, nitro, and aspirin. Oxygen is usually the first thing that you would put on the patient, but in terms of memorization, MONA seems to be a very common mnemonic to remember the treatment for myocardial infarction. So continuing on with the anticoagulants, specifically the oral agents, Coumadin would be a common oral agent anticoagulant, and basically Coumadin decreases the formation of blood clots but prolongs bleeding time. So we would want to monitor laboratory values such as the INR or PT, and their ranges are listed here. The antidote, meaning the reversal for this medication, would be vitamin K. So patients that are taking these medications from the nursing standpoint, we would want to educate to avoid foods that are high in vitamin K. So an example would be green leafy vegetables such as spinach would have to be avoided. You want to educate the patient on bleeding precautions. So observing for signs of bleeding from the mouth, any kinds of mucous membranes, think lines, drains, and tubes, as well as any abnormal bruising. Xarelto or Pradaxa are two of the newer anticoagulants and are being utilized more for things such as AMI. And heparin is something that is naturally found inside of our body in the liver and in the lining of the blood vessels, but it can be administered through medication form. So this medication is poorly absorbed through the GI tract and must be given subcutaneously or in the fatty tissues or intravenously IV route. So the injectable would be the low molecular weight heparin, such as Lovenox or Atrixta. Lovenox would probably be the more common of the two. This is a high alert medication, meaning that the patient has a risk for bleeding. So a lot of times there are protocols in place within the hospital that nurses must double check these medications. The onset is about 30 to 60 minutes and it peaks at 2 hours. So you would really want to monitor the APTT lab for effectiveness. Heparin-induced thrombocytopenia is a serious thrombolytic event that can occur as a result of taking this particular medication. So both the homeostatics and thrombolytics essentially shorten bleeding time. Example would be Amicar, and a side effect would be anaphylaxis, which is a severe allergic reaction, or thrombosis, meaning a blood clot. So really the goal is to promote clot destruction, but there is a narrow margin of safety. TPA, it would be another example of the thrombolytics, and the side effect of this would be hemorrhage. And so if the patient starts bleeding, the medication would essentially be stopped. Intracranial bleeding or bleeding inside of the head would be more common from this medication. And so frequently assessing alertness or level of consciousness is relevant from the nursing standpoint. So now moving on to hematopoietic drugs. Epogen is a medication that is used to promote or increase red blood cells. This medication is very costly, very expensive. It's given in small volume. And then Neupogen, which essentially increases white blood cells. And then Numega or Promacta, and this increases platelet production. So a lot of times these medications are used in anemias, which we'll see on the next slide. So again, the hematopoietic drugs would be used to treat anemia. So specifically pernicious anemia or megaloblastic anemia. These patients generally have a B12 deficiency, and so you want to increase the B12 levels, and that is done through folic acid or cyclophosphamide. And so these are just vitamin B products basically that will increase red blood cells. In talking about iron deficiency anemia, this is pretty much the most common form of anemia. And so this is just due to a lack of iron, essentially from diet. And so we would want to supplement with iron-rich foods. You can also promote ferrous sulfate, but it's best absorbed with vitamin C. So the patient would have to take both together. In severe cases, patients may require an iron dextran infusion or iron injections of intramuscular ferrous sulfate, and this would be deep intramuscular injections. So moving on to some additional questions. A patient is being discharged home after receiving treatment for a myocardial infarction. The patient will be taking Coreg. What statement by the patient demonstrates they understood your education material about this drug? And the answer is C. I will monitor my heart rate and blood pressure while taking this medication. Remember, this medication can lower both the heart rate and blood pressure. So monitoring the blood pressure and heart rate is essential during administration or prior to administration of this particular medication. So moving on with another question. A patient recovering from a myocardial infarction is complaining of the taste of blood in their mouth. Upon assessment, you note there is bleeding on the anterior gums. Which medications could cause this? And the answer is C, Lovenox. So remember, Lovenox would put the patient at increased risk for bleeding. The patient receives Lovenox postoperatively. The nurse teaches the patient about this medication and evaluates that learning has occurred when he makes which statement? So the answer would be B. It increases the time it takes for me to form a clot. Your grandma with heart failure is telling you of her sudden vision changes that include seeing halos. Which of the following medications do you suspect is causing this? The answer is D, digoxin. Again, remember digoxin can put the patient at risk for digoxin toxicity, which visual changes or disturbances would be a sign of digoxin toxicity. All right, so a few more questions. What is the difference between anticoagulants and thrombolytic drugs? Now remember, one prevents clots and the other lyses the thrombus or clots. And what lab measures the effectiveness of warfarin or heparin? And remember, we want to monitor the INR, PT, and PTT. All right, so moving on with cardiac part 3, we will start to talk about shock and the different types of shock. Okay, so there are different types of shock. Cardiogenic would be most lethal. And this is because of a poor pump. So you can see sort of how this would have the most significant effects on the body if the pump itself is not working well. Neurogenic is a sudden loss of sympathetic activity, and this is usually as a result of accidents such as spinal cord injuries. And then hypovolemic, which is about up to 30% of the death rate. And hypovolemia usually occurs as a result of the loss of blood or fluid. Septic shock would be as a result of an infection that has crossed into the bloodstream. It has a very high mortality rate, up to 90% depending on the type of organism. So early intervention is key from the nursing standpoint. And then anaphylactic shock would be as a result of a severe allergic reaction, and there's up to 1,000 fatal cases a year for anaphylactic shock. So this is a diagram basically talking about linking the different types of shock to some of the signs and symptoms for those of you that are more visual learners. So this is another chart here that shows the different types of shock and essentially what causes the different types of shock, and then what did they result in terms of patient presentation, signs or symptoms. This diagram here is a little clustered and sort of hard to follow, but what I want you to just take from this is what organs does any shock really affect? So there is an effect, a direct effect on the kidneys. So renal failure is possible, lung failure, gastrointestinal effects or impacts. And so really when you think about shock or the different types of shock, these main organs would be the ones affected. And then let's not forget about the lead organ or the pump to the body, the heart. So this is a diagram here talking about the clinical picture of a patient in hypovolemic shock. And remember that hypovolemic shock is usually a result of a decrease in volume. Bleeding would be one of the most common causes. And so sometimes we can see signs of obvious bleeding. Other times we cannot. Sometimes the bleeding may be internal. So rapid heart rate and low blood pressure would be two of the vital signs that we would observe for a patient in hypovolemic shock. The patient may also experience increased respiratory rate. Altered mental status or disorientation in severe cases once the patient is symptomatic may occur. Also, the Foley catheter, you may notice that the patient has a decrease in urine output, because remember the kidneys are that organ that is essentially a predictor of oxygenation. If the kidneys are not receiving oxygenated blood, they will not produce urine. And so the treatment would be IV fluid replacement and or blood transfusion, in addition to finding out the cause of bleeding and potentially stopping the cause of bleeding. So this diagram here would be that overview of sepsis, and this is that bacterial invasion that crosses into the bloodstream. Septic patients will have different stages, so there may be varying signs and symptoms, but the patients may have altered mental status, a fever, tachycardia, increased respiratory rate, and really the difference here would be the increased white blood cells. There are different phases, like I said. So later phase would be the cold phase, and this is when the patient has cool, clammy skin. And the cool phase is when the higher chance for mortality of the patient may occur. So for anaphylactic reaction, we want to immediately think about the A, B, C, D, E. What causes? We want to inspect the airway, the breathing, the circulation, disability, exposure. You want to manage any kind of acute life-threatening airway or breathing or circulatory problems. The patient needs to be flat. You want to raise their legs to promote the return of circulation to the heart. Really, for these patients, they may need medications to sort of stop the allergic reaction process. So high-dose steroids, A lot of times these patients would receive things like epinephrine to vasodilate and increase the circulation to the vital organs. So here is a list of the drugs for shock, or the medications for shock. So you really want to replace the fluid with crystalloids or colloids. The drugs for anaphylaxis would be listed here. I mentioned epinephrine. Benadryl would be another one, that antihistamine medication. Albuterol for breathing, and then the corticosteroids to decrease the inflammatory response. Vasoconstrictors and vasopressors. So dobutamine helps essentially to, it works on the alpha and beta receptors, and the side effects would be dysrhythmias, but it helps to constrict the vessels, basically increasing cardiac output. And then norepinephrine or Levophed. When patients require Levophed, there's sort of a slang saying, Levophed, leave them dead. And this is because these patients that are requiring Levophed as a vasopressor or blood pressure support are very critical. And then inotropic drugs, remember, increasing contractility and heart rate would be examples of medications that we would use for heart failure, such as digoxin. This is a really good chart here that talks about the different types of pressors and their uses with shock and their main effects. So this is a emergency drug chart with an acronym here, LEAN, and it talks about the different types of medications for emergency drug treatment. So lidocaine, epinephrine, atropine, and naloxone or Narcan. And this talks about some of the signs and symptoms or side effects that these medications may be used to sort of treat and what may happen when the patient receives these medications. So moving on to drugs for dysrhythmias. And so dysrhythmias is sort of it's a word used to talk about abnormal rhythms. And so there are different types of abnormal rhythms, which you can see are listed here. And we will discuss some of the dysrhythmias on the next few slides. And generally, these dysrhythmias occur because of a disruption in electrical impulses. So the electrical impulses essentially are what spread throughout the heart to basically cause ventricular contraction. And you can see here, starting at the sinus node, how those electrical impulses travel throughout the heart. And so this is just an example here of the myocardial conduction. This slide here is breaking down myocardial conduction. So I will leave this slide for you to review on your own if the pathophysiology is something that you need review on. What you can see here on this slide is an ECG or an electrical cardiogram of the normal sinus rhythm. What I like about this slide here is that it breaks it down and color coordinates the different waves and segments. And so you will learn in detail later on about ECGs throughout the nursing program. So that's not really our focus, but I do want you to see the components of a normal sinus rhythm. And so this next slide here is the classifications of an arrhythmia. There are different characteristics. And so there are the flutter, which is rapid but regular contractions, a tachyarrhythmia, which would be an increased rate, or a bradyarrhythmia, decreased rate. Fibrillation is disorganized contractile activity. And so there are different sites involved, and what you can see here is the breakdown of the sites involved. This is another slide here that shows the normal sinus rhythm up top, and then the other arrhythmias that can be occurring towards the bottom. And this is another slide to sort of summarize the dysrhythmias and the atrial ventricle rates as well as rhythm. But again, your focus would be how are we treating it from the medication standpoint. So there are drugs for dysrhythmias, and the drugs for dysrhythmias would be class 1, which would be, for example, quinidine or lidocaine. And these medications work by blocking the sodium ion channels. Remember, inside of the heart, we have that sodium potassium pump that aids in cardiac conductivity. And the next would be the cardiac classification 2, or our beta blockers. And one thing that I want to highlight is that we've learned about beta blockers roughly 3 times throughout this slide, discussing different types of cardiac conditions that may require the use of beta blockers. And so these particular medications are good in dysrhythmia such as sinus ventricular tachycardia, atrial fibrillation, or ventricular tachycardia. So the next class would be class 3, or potassium channel blockers. Amiodarone is probably one of the most common dysrhythmia medications, and these medications generally essentially increase the risk for life-threatening dysrhythmias such as torsades. Then the next classification, or class 4, would be calcium channel blockers, and these decrease depolarization and the O2 demands of the heart. So verapamil or diltiazem. Diltiazem is probably the most common out of this classification. And then there is a miscellaneous, or adenosine, digoxin, or mag sulfate. So remember that dysrhythmias may also be caused as a result of electrolyte abnormalities or imbalances. So it is really important to monitor the patient's electrolytes. This is a chart here depicting the different classifications of the anti-dysrhythmics, examples, as well as the uses and mechanism of action. So this chart here would show the anti-arrhythmic drugs or medications based off of the mechanism of action. So I would like you to review those charts that you saw, but remember, follow that study guide. The study guide that is up on Canvas for you, that will be your key to success on the next exam. We will close up with some review questions here. So true or false? Septic shock causes a system-wide vasodilation, which leads to an increase in systemic vascular resistance. In addition, septic shock causes increased capillary permeability and clot formation in the microcirculation throughout the body. This would be false. Your patient's blood pressure is 72/56. The heart rate is 126 and the respiratory rate is 24. The patient also has a fever, warm, flushed skin, and is restless. You notify the physician who suspects septic shock. You anticipate that the physician will order what treatment first. So the answer would be B, IV fluid bolus. Remember, we need to get the fluid inside of the vessels increased. We need increased volume, which will essentially help with that blood pressure and to slow the heart rate down. The MD orders a dobutamine on a patient in cardiogenic shock. What should we closely monitor for after starting the medication? And the answer is C, worsening hypotension. A person with a heart rate of 170 beats per minute and a normal QRS duration would most likely be experiencing a tachydysrhythmia from where? The answer is B, originating from the atria. And I just want to close this in answering this question: which electrolytes are important for cardiac function? Potassium, calcium, and sodium would be the 3 most important or relevant electrolytes for cardiac function.